So, so welcome everybody. I'm Elena Rios, President and CEO of the National Hispanic Medical Association. Excuse the telephone. Our website is there at the bottom, and our social media for our Twitter account at NHMA-MD and our Facebook. We'd like to welcome you. Next, okay. And I think my message as the opening for our event is to encourage everyone to consider enrollment in the clinical trials for the very important COVID-19 vaccines that are open and have been enrolling people since this summer. And I believe that both of these websites represent companies who have gotten to about halfway towards their goal of 30,000 people to be enrolled in the vaccine clinical trials, so that we can have a safe and effective vaccine. The first website is www.coronaviruspreventionnetwork.org, and that is the website of the National Institutes of Health, who is working with Moderna, a company who has one vaccine. And then the other website, www.covidvaccinestudy1.com, is the website for Pfizer, one of our partners, and also another company with the clinical trial. Hopefully, I think it's a little further along, because I just saw that Pfizer was asking or requesting formal approval process now for FDA in the emergency situation that we're in. I also want to just invite everybody to consider joining NHMA's foundation. We have a scholarship award ceremony, and we are honoring some important leaders from around the country who will give words of wisdom as they accept their awards. And then the scholarship students and their parents will also be accepting their awards. We are hoping the Surgeon General, Dr. Adams, will be able to make it. And we have others from around the country, such as Dr. Eduardo Sanchez from the American Heart Association and others being honored. November 19, and this is our NHHF website is called, the actual website is nhmafoundation.org. And then lastly, we have an annual conference, and our 24th annual conference, which was postponed this year due to the COVID pandemic, will be virtual March 17th through the 20th, 2021. We have the majority of speakers who had, graciously accepted to move their talks to next March, but we do have a need for more speakers. And if you go to our website, nhmamd.org, our conference speaker abstracts and our poster abstracts should be uploaded today. We have a deadline of November 30th to package the rest of the conference so that we can announce it. And I have a special survey before we get started. Sergio, just give me one more minute. And I'm going to ask Ben to let me know how people answer this. I'm assuming they answer it by putting an information in the chat.
It will be a survey that we can start once you say we can go.
Well, that didn't answer my question. So could you please explain how everyone answers the survey?
Yes, a window will pop up when we start the survey, and anyone on there can choose the button, their choice.
Okay, and we will wait, what, a minute or so? Half a minute?
Yes.
Okay, so this survey is very important for us and for our partners. We have a survey on systemic racism in healthcare for the NHMA participants tonight. This is from the Pfizer Multicultural Center of Excellence, and they are very interested in helping to learn more about our audience's perceptions of racism. So number one question, have you ever experienced racially charged actions, derogatory language, discriminatory behavior, stereotyping, or hate speech, even if subtle, at any point in your career? And if you're a doctor, a medical student, resident, we're looking for your answer. So go ahead and answer. Okay, Ben, did people answer?
Yes, let's get 30 more seconds.
It's just 5 questions, so if everyone can just please answer and submit. Okay, the next question. Oh, we're sharing the poll results. Okay, so not surprising, 78% said yes. And I have to tell you my story. I actually got stopped by the police on the block where I lived in medical school the night before a final exam that I didn't pass. I was so, it was terrifying. But I had a roommate with me and she went and talked to them because I just couldn't get out of the car. But anyway, number 2, have you ever witnessed racially charged actions or discrimination against patients while seeking or receiving care in a health institution? Have you ever witnessed racially charged actions or discrimination against patients while seeking or receiving care in a health institution? Please answer and submit, please. Okay, looks like we've got the same pattern here. 78% said yes. And again, not surprising in our communities where doctors and those that are patients may not understand other patients and be, you know, racially charged actions happen when you're stressed in a healthcare institution when you're sick or you're facing people that are sick. Okay, number 3, from your experience, in which industry area would ending racism make the most impact on patient care in the short term? And choose only one. We're asking for, from your experience, in which industry area would ending racism make the most impact to patient care in the short term? Short term meaning, you know, in a year. And please choose one and submit. And short term might be, you know, 2 years. If you're talking Congress and policy, but it's short term meaning it'll happen sooner than, you know, than waiting a lifetime. Okay, looks like hospitals and healthcare facilities have the opportunity to make changes, and I would hope that that means the decision makers don't have as many barriers or length of time to get their policies implemented. Okay, next question, number 4. In which of the following areas would you like to see the pharmaceutical industry focus its diversity and inclusion efforts? And again, just pick one. Oh, I'm sorry, there's an answer that says all of the above. Do we have that answer? All of the above: executive leadership, supplier diversity, diversity in clinical trials, staff and manager levels, scientists and researchers. So all of the above. Alejandro, you have a lot of work ahead of you. And the last question is, we want everybody to answer in the chat box at the bottom of your screen. Please suggest one way in which you would disrupt systemic racism in healthcare. And please provide your answer in the chat box. We'll wait a minute. And again, we realize that you are all in different stages of your career in healthcare or interested in healthcare. Just one way how you could disrupt systemic racism. Go ahead and keep answering. We'd like to get some answers. How can you disrupt, wherever you are in your career right now, how can you disrupt racism in healthcare? And I'll just read some answers. Opening the doors to accessing jobs and opportunities for minorities in the pharmaceutical industry. Offer patient-centric care. Improve widespread unconscious bias training. Those are all good answers. Must have diversity throughout companies and organizations that represent our community. Provide better public options to low-income community, and I believe that's a public option in terms of insurance. Could be other types of public programs. Change some of what is taught in medical school, where I find embedded racist elements in risk formulas and other diagnostic testing and algorithms. Of course, if we had more diversity in the medical school faculty, maybe we would have more educated people about different communities too. And change the leadership. Yes. So lots of ideas, keep them coming. I am now going to turn this program over to Dr. Sergio Rimola, who is an OBGYN doctor with the Inova Health System in Northern Virginia. Sergio, you need to tell everybody about all your activities with public service. I know you are on advisory committees to the governor, and Sergio is going to moderate this session. And thank you very much to our partner tonight, Pfizer, and to our speakers, and to, of course, all our audience. And I just have to give a plug for, we will have a chapter on detention centers from Miami on Thursday, and next week from California, we're gonna be listening to our Senate and Assembly healthcare leaders in the state of California about what's next in policies for COVID-19 and chronic disease. Thank you.
Thank you, Dr. Rios, for the introduction. Good evening, everyone. On behalf of the NHMA Washington, D.C. Metro chapter, I would like to welcome everyone. My name is Sergio Rimola. I am the NHMA DC Metro co-chair. I am a board certified obstetrics and gynecologist, and I'm an attending physician at the Nova Fairfax Hospital. I hold 3 faculty appointments at 3 local medical schools in the area. And also I am a board member of the Virginia Latino Advisory Board. I will, as follow, we are going to present a short video. It's a 3-minute video provided by the American Dairy Association Northeast, ADAIN, to highlight some of their key health and wellness initiatives. Liz Jakowicz, she could not be here, but she's the nutrition specialist for ADAIN. And however, she is your main point of contact for the DC metro area and all things dairy related should you or your patients have any questions. In the video, Liz's colleague, Michelle Barber, is future. However, please note that Liz covered the DC metro territory. Enjoy the video.
Hi, my name is Michelle Barber. I'm a registered dietitian and nutrition specialist with American Dairy Association Northeast. For those of you who are not familiar with us, we are a nonprofit organization representing over 10,000 dairy farm families in New York, New Jersey, Pennsylvania, Delaware, Maryland, Northern Virginia, and the District of Columbia. We are committed to nutrition education and research-based communications. We have a long-standing history of working with schools, retailers, and health professionals to help educate on the positive health benefits of consuming dairy products, like milk, yogurt, and cheese, as part of a healthy diet. We collaborate with a variety of partners in the private and public sector, including the local affiliates to Academy of Nutrition and Dietetics, American Academy of Pediatricians, American Academy of Family Physicians, National Medical Association, National Hispanic Medical Association, and National Association of School Nurses, with a common goal to foster a healthier nation. We work with these local affiliates and their leadership to provide support for annual meetings, experiential learning events like in-person and virtual dairy farm tours, as well as educational events to keep you up to date on the latest dairy research and trends. I wanted to take a quick moment to share our website, americandairy.com, with you. Here you can access free downloadable resources ranging from general dairy nutrition and research to sustainability practices. Here, we also have information on 2 of our school health and wellness initiatives, Breakfast After the Bell and Flavored Milk in Schools. Breakfast After the Bell is an initiative that ensures children are able to get breakfast as part of the school day. Kids will often miss breakfast at home or in the cafeteria, so providing breakfast in the classroom with programs like Grab and Go, Second Chance Breakfast, and Breakfast Vending helps close the nutrient gaps in children's diets while significantly boosting school breakfast participation. And now, more than ever, it is so important to keep school meals an integral part of the educational day. Schools are serving meals, breakfast and lunch, everywhere and every way possible in order to ensure children still have access to the essential nutrition in school meals. Flavored milk support ensures children have a choice between white and flavored milk in schools. The dairy industry has made great strides in reducing the sugar content by 45% over the last 10 years. We are proud of this, but we are even more proud of the fact that any cow's milk, white or flavored, provides 9 key nutrients for optimal health and growth in children. Also, here are our social media handles. So if you don't already follow us, please like and share our content, as we are your dairy resource.
Thank you very much. Before we introduce the first speaker, I just would like to do over some housekeeping items. The presentations will be followed by 10 to 15 minute discussion. The microphone will be muted. If you have any questions, you can type it in the chat box. Recording will be available next week at the website of NHMA. Is www.nhma.org. nhmamd.org. And there is going to be some instructions. We will receive an email in about a week, a thank you email, and you will have instructions to get your CME credit for this webinar. And will be on the website for up to a year. This presentation will be posted. Here I have the learner notification. Now I'm going to introduce our first speaker, Dr. Rebecca Vargas-Jackson, MD, surgeon and infectious disease specialist, bilingual, bicultural physician working over 25 years in United States and overseas. She provided direct care and training for HIV and other infectious diseases. She served as co-principal investigator on first AIDS clinical trials for minorities at Howard University. Was the first director of the John Mason Uncivility Area Health Education Center. Dr. Vargas-Jackson has been working with other pandemic events, HIV, TB, Ebola, and now COVID-19. She is a organizer of the annual International Stigma Conference at Howard University, and she is currently working with the Commonwealth of Virginia Department of Emergency Management on COVID-19 Equity Group on the design and implementation. Please, Dr. Vargas, you can start your presentation.
Dr. Vargas, you're muted.
Good evening, everybody. Yeah, I know that it was muted. Sorry. Buenas noches, colegas. To start my presentation, I want to remind everybody about some facts of life that sometimes we don't think about on a daily basis, but we should. Like life is a limited cultural event. And we know it's very limited. And everything we do, we eat, we think, and everything around us is culturally bounded. And remember, life is a combination of genetic lottery and a geographic accident. So when we're talking about the new immigrants, and I bet that none of us have asked to be born either in New York or in Argentina, Peru, or South Sudan. So remember that when we are treating our patients and we are in front of people. Next, please. Health literacy, that is the topic that I was trying to address. And health literacy is a cultural, cognitive, and social skill. When we talk about skill, it's something that we need to learn. So it's very important to don't judge a patient because they don't have that skill. Perhaps nobody has taught them. And that skill determines the motivation and ability to individuals to gain access to and understand everything that is health related, and they are going to need it. Next, please. I think we jumped one. The issue is that health literacy sometimes is confused with health education. We know that health education is just a public health activity. So we don't need to confuse that, because in the health education arena, we don't address issues related to personal motivation, cultural background, social skills, learning abilities or disabilities, or stigma. Next, please. And to summarize that, in that picture, you can see how different is the health education, and health literacy is a very multi-dimensional concept. Next. Health literacy is facing this challenge that the individual skills we are building in people need to be in accordance with the demands and expectations. If we see today, the Affordable Care Act is being changed. So the skills that people was developed need to be improved, or they are not going to get there. Next, please. Some of the topics that we address on the health literacy arena, many of you are familiar with that: cultural competence, diversity, health equity, class standards, motivational interviews, diabetes, hypertension, communication, social determinants of health, and many more. Next, please. So that means that we have some of the pieces of that puzzle. So we have the training. The point is, like, why are we not able to use it? And sometimes we believe that the patient has enough health literacy skills. If they don't, and we say, I'm compliant patient. Next, please. So health literacy is doing that for us. It provides to us the shape of that puzzle. So health literacy embodies the skills that each individual needs to develop. I'm not talking only about the patients or clients. I'm talking about us, because I don't know if all of us know how to assess health literacy skills, how to use validated tools. So everybody will learn how to do that if you are following the health literacy kind of trainings. Next. That is the main reason. 9 out of 10 adults here in the US have difficulties using everyday health information. I'm talking every day, I'm talking CVS pharmacy health information. I'm not talking about a kind of a consent form or something in that level. And that is being reported year after year. And the issue that people can read doesn't mean that they have enough health literacy skills so they understand what we're saying. Next, please. Why people need the health literacy? Well, they need it to navigate the healthcare system. They need to locate providers and services, to share the personal information. When we see that a health history is not complete, it's not because people is lying to us, it's because they don't have enough health literacy skills to provide with that particular information. And they need to understand these mathematical concepts such as probability and risk. It's important for decision making. Wearing a mask, don't wearing, who I believe. If you don't have enough health literacy skills, it's very difficult to make that decisions. Next, please. I think we jumped. Okay, and other reasons are that because people need to understand different things like public advisories, wear face covers or not, test results. What do you mean with that result? Information in the media, and then medication adherence. Next, please. There are critical skills that people need to have to really get into the health literacy arena. Communication, it's one important one. Comprehension, that is very tricky because in comprehension, people try to make people repeat things, but we don't understand that perhaps the problem solving skills don't exist over there. So it doesn't matter how many times they repeat something, they don't get anywhere. The navigation of the system, the cultural background, belief and bias, now we see that. Governmental mistrust is happening here today, and when they need additional assistance. Next, please. And health literacy is based on patients' computer literacy. Every senior citizen have computer literacy? Maybe not. Cultural literacy, they need to understand the cultural similarities and differences. And I don't mean just the patient, I mean the provider. What about if we don't understand the cultural differences or similarities of some of our patients? The language literacy, I don't mean Chinese or Spanish or Greek, I mean the language that the physicians and the system is using. Perhaps it's not a language that the patient can understand. Financial literacy, now the co-pays and all of these issues. Information literacy, media literacy. Who can tell this patient with low health literacy what is a fake news or not, and visual literacy. Next. The health literacy and as individual, but a systemic factor plays an important role. Some community-based organizations are going to influence that, and some educators and communicators, faith-based organizations may provide the right information on misleading news and electronic media. We know what is happening with that. Next, please. So health literacy is the only path to health equity. Health literacy requires a little bit of knowledge of basic biology and health topics, and I don't mean that they need to go to medical school, but a basic knowledge is needed over there. People with low health literacy skills doesn't have enough knowledge to understand what is the information and what is misinformation related to causes of diseases. Without this knowledge, they cannot understand the relationship between lifestyle and what other factors are going to take them to different outcomes, like diet, exercise, the use of face covers. So without improving health literacy, we are never going to be able to really get to the health equity that we need. Next, please. And just put it over there, but so everybody can remember that we are not looking for equality, we're looking for equity, and that is another topic to talk about. Next, please. And that slide is not complicated. Health literacy, you see, is kind of influenced by cultural, language, social support, the vision, hearing, memory, etc., the race, ethnicity, and all of this is going to make us possible to access the healthcare system, and then the interaction with our providers and the self-care. And based on all of these, we're going to have some particular health outcome, unfortunately not very good for our communities. Next, please. Why do we need to know the health literacy of our target population? Because only 12% of the US population is health literacy proficient. That's National Assessment of Adult Literacy. So basically 90% of adults lack of skills to manage their health. About 14% of adults score below basic. Next, please. In addition to that, because the primary responsibility to improve health literacy is on us, is the healthcare providers, the public health professionals, and the public health system. We need to work together to improve health literacy of our populations. And patients with low health literacy are going to misunderstand, are going to have problems with compliance and with medication adherence. Next, please. We need to remember that. The green is where we're supposed to have our patients so they can really work with us in a team effort for their health. And if you see, it's just 12% of the population. People in the intermediate make mistakes, but with some minimum effort, they can increase their health literacy skills. Basic and below basic needs a lot of work. Next, please. If we look by race and ethnicity, if you see Black and Latino communities, it's unbelievable that they are just 2 or 4% health literacy proficient. And even in the best case scenario, the white community's API is like 14 and 18%. So we have a lot of work to do in the health literacy territory. Next, please. So health literacy is called the overlook factor because scholars are describing it like a silent epidemic that's challenging the functioning of the healthcare systems globally. And I don't need to mention that people is not going to be willing to get involved in the provision of care, and they are going to hospitalize more frequently. And unfortunately, they can repeat everything you tell them without understanding the meaning. And that's the warning for people who try to say like plain language and maybe teach back. Well, there are many studies now that tell us that people can repeat everything. Next, please. And that is what is happening now, that one of the barriers is low literacy. And if you see over there, 18% of the US population scores below level 1. The international score for below level 1 is 16%. And we are talking about third world countries. So we are scoring worse than third world countries. And 23% of our population is scoring level 1. So 18% below 1, 23% level 1, and goes from 1 to 5. So it's very scary if we look about literacy. Next, please. So 99% of Americans can read. That doesn't mean that they are literate. And only 12% are health literate. Next, please. The challenges that we're facing in health literacy are the population changes. The aging populations and the millennials and Gen X, they receive information and they absorb information and retain information, can work with the information in very different ways. And then with the limited English proficiency and other areas. The main problem here is that the compromised quality of care when patients' health literacy is inadequate and providers are not aware of it. Next, please. From that one, I just want to highlight that the higher cost in healthcare when we deal with health literacy. Next. And then to design some culturally tailored interventions, we need to assess and develop. Assess not only the users, but the providers' knowledge on that. Based on that, we can develop the materials that we need for our target population. Next, please. And then we need to continue talking with the target population, understand their beliefs in languages, use validated tools always, and pilot testing anything we're trying to introduce as new concept. Next. So we need to acknowledge some of the differences and understand the difference and the cultural difference that exists over there. So some of the examples are that there are some taboo topics that we need to be aware of and value the traditional medicine that some people is bringing to us. The body language is very important to address as well. Next. So some strategies are the use of validated tools and assess all your patient population. They need to be reassessed, randomly reassessed at least once a year. And as I said, use simple language. Remember, low health literate people can repeat almost anything without understanding the meaning. They cannot connect the dots, as we know. Next. To improve health literacy skill, as I mentioned, we need to offer training, conduct assessments, promote community education, and then design materials and interventions that are appropriate to the health literacy, language, and culture of the target populations. Next. Some of the strategies for the staff is to talk about that. How important is the health literacy in any interaction provider and patient, and how they need to learn how to assess health literacy skills of all their patients, use validated tools, and develop strategies. CDC, making health literacy real, is one of the most important strategies. Next. So for organizations, I don't need to go to a lot of details over here, but the most important probably is the quality assurance. After we develop any kind of intervention, we need to measure the quality assurance, and we need to include the communities in any kind of intervention development. Next. And that is the problem. Just 10% are the ones who are skilled to understand and follow our instructions. What about the other 90%? Next. And I don't want to mention something that probably all of you already know, that patients with low health literacy more likely to be in the emergency room, more days in the hospital, treatment plans are going to fail, and is higher mortality rates. Next. The National Action Plan to Improve Health Literacy is over there in all the federal websites. Next. And that is the summary. Remember that health literacy is a silent epidemic. That just 1 out of 10 people are going to be able and capable to understand and following your recommendations. What we need to do, assess, and assess. Then design based on that assessment, get the management support, implement, and do your quality assurance, and make constant adjustments and corrections to any intervention you are developing. Thank you so much.
Thank you, Dr. Vargas-Jackson. Great presentation. Now I'm going to introduce our next speaker, Dr. Britt Rios-Ellis. She is the incoming Executive Vice President of Academic Affairs and Provost of Oakland University in Michigan. Since 2014, she has served as the founding Dean of the College of Health Science and Human Services at California State University, Monterey Bay, where she has launched the first Master of Science Physician Assistant program, among other degree offerings. From 1994 to 2014, she was a professor at California State University, Long Beach. She is the founding director, Center for Latino Community Health, Evaluation and Leadership Training at CSU, Long Beach, and the Barrio-based Centro Salud, Es Cultura. She was awarded the university's highest honor of Outstanding Professor in 2013. Thank you, Dr. Ellis.
Thank you so much. So very nice to be here, and what a fantastic presenter Dr. Vargas is. I just invited you to another event, so I hope you look in the chat. So we all know these institutional barriers to care, which have been completely worsened, I'm just going to be blunt, by the current administration in terms of the xenophobia, the language discrimination, the lack of, I kind of tend to shy away from cultural resonance because I see a lot of folks who aren't so culturally resonant with certificates that say they are culturally competent with certificates that say they are, right? I attended a training, therefore I'm an expert. And we really do need to move beyond that. So I like to refer to it as cultural resonance because I think that speaks to the individual who is receiving the information, right? Or is receiving the interaction. Cost, transportation, lack of knowledge, which I think Dr. Vargas spoke so eloquently about, fear of deportation, childcare, etc. All of these things are very formidable barriers to care. And for this reason, even though I think for a lot of other reasons, healthier Latinos experience disproportionate rates of disorders and are more likely to underutilize health services for a variety of reasons. Next slide, please. So when we look at the Hispanic paradox, we see an interesting thing, because we see that immigrants are usually healthier, and then after they've been here for 10 years or more, things tend to go south, south in terms of bad. So selective migration hypothesis has helped us understand that folks who are working so hard to survive are often, folks say super Mexicanos, they're actually super stressed, right? And I would say that goes across the board for all Latinos. So the effects of acculturation do cause poorer health status and behaviors, including depression, cardiovascular disease, smoking, chemical use and dependency, sexual risk, et cetera, et cetera. And despite this, we do see that Latinos live longer overall. And I'm very interested in the census data when it comes out again to see whether or not this is held, because surely people have had to withstand very formidable attacks on their health and well-being in the past 4 years. Go ahead, next slide. So, you know, one of the things that I think is really important is to understand the cultural factors and how much they relate to the Latino patient, particularly if the person has immigrated to the US. And we're having to deal with this on a number of things, particularly now with the pandemic, because most of our educational systems have gone virtual. Folks, you know, oftentimes aren't messaging families, they're messaging individual students. They're not associated with the context of the patient. And we have to go further and further in terms of understanding that context, particularly with telemedicine and the things that we're working with now. We also have to understand that structural and systemic racism is a public health problem. It has been a public health problem for a very long time. It's not just a behavioral issue, it is a detriment to our health. And I think we also have to understand the new reality for so many folks who are immigrating to the country. Being Latino or Latinx or Latinesh, however you pronounce it, is a new reality for so many, right? And studies have shown that it takes a while to even understand that, because you come with your national origin. So, you know, we can look at, I dealt with one patient situation where there was a patient who was an immigrant, obviously from a rancho in Mexico, very, you know, kept her eyes down out of respect. And she had a sore in her mouth that was, she had 5 people around her ready to remove her child from her custody. They thought she had Munchausen by proxy because she'd recently lost weight. And they were ready to just assume that without, and a friend of mine who was a physician walked in, and sure enough, it was actually sores in her mouth. And it had nothing to do with her desire or psychological position to harm her child. Also, mal de ojo, and understanding why Latinos tend to touch babies, right? This is something that, and we also know with kangaroo care and all of the things that we know about perinatal health, that skin on skin is actually very good for children. So this is a good thing, not necessarily a bad thing. And also familismo, and working with physicians to help people understand that you've actually, when you have a whole familia come into a hospital room, you've actually, if you're a good physician, you've got a care team, and you've got someone that can really help this individual adhere to your instruction, not a bother, and not a group of people who's interfering with the care of the patient. Although some imply that culture could possibly be a contributing factor, at National Council of La Raza, now Unidos US, the Latino Health Communications model demonstrates the opposite. And I think it really points to the fact that we need a Latino specific model. And I'm going to talk a little bit more about how we can integrate that into our understanding of how we improve patient-provider interactions. Next slide. So it really looks at the Latino Health Communications model informs cultural, my phone's ringing, cultural constructs specific but not inclusive to diverse Latino subgroups. It helps people establish better relationships, more culturally resonant and congruent relationships. Optimizing these constructs with health interventions helps really folks understand the belief systems and work with those belief systems. And it creates optimal health status and access dynamics within Latino communities, because the provider can understand a little bit more about some of the things that the patient is navigating. Next slide, please. So it also facilitates health and human services providers and helps them resonate more effectively with Latino patients. And it helps us understand the need to transcreate as opposed to just translate messages, and how that can help us not have things get lost in translation. Next slide. So we're looking at constructs like familismo, right? And really looking at how family, like I just talked about, can be the care team around a patient. How personalismo and really developing those personal relationships are really essential for folks, right? We don't just want the information, we want a relationship with the individual. Presentismo, which can be a positive thing and a negative thing. It can be a negative thing because maybe if someone's in the mood for sexual relations, they might not use a condom. It can be it can be a great thing because when you go to a Latino party, there isn't usually an end time. They usually play themselves out. Everyone has a good time until it naturally ends. Respeto is very important. Comunitarismo and people banding together around a certain cause. Fatalism or fear, fatalismo, was really looked at as something that was very negative. But then what we're finding is that fatalism is actually more often fear, right? And that's a problem. Confianza, and the really important part about valuing trust and building trust. And simpatia, really valuing harmony over discord. So people might nod as if they understand, but they might not actually understand. So that's where things like motivational interviewing can be really transcreated into a strong way of understanding whether your patients are getting the information. So what are assets in your Latino community that you can use to better target health information? That's just a question for everyone in the audience. So let's talk a little bit about transcreation. Can you go ahead? Next slide. So translations are inadequate, we know that. There's a need to relate to groups of people within different contexts, right? It's like trying to translate lemon, right? Doesn't really work. Limon, lemon, yeah, things can get lost. We keep reinventing the same messages, materials, and programs with very little success in impacting health behavior. And we also define populations as hard to reach when they're actually historically neglected and chronically underserved. Next slide. So transcreation helps us reach audiences and resonate with audiences. I'm going to go back to not just the competence, but the resonance from where they stand to ensure that message and recipient are aligned. Transcreation isn't a buzzword for translation. It's a real methodological process by which messaging is contextualized through language, art, visuals, and it works to incorporate populations that have been historically underserved while improving health behavior and outcomes. Transcreation is the process by which materials are not only translated into a language, but also into a culture. It moves beyond language so that folks can fully understand the information. And we need to ask ourselves, do we want our message to be accurate? And accuracy is a really important thing when we're dealing with all of the litigious bureaucracy that we have around health. Or do we want our messages to be effective, right? And that is a really key question that we need to continuously battle with. And translation can be seen as the key and transcreation as the door. So what's the good of a bad key when you can't really open the door, kind of thing? Go ahead. So the Pan-Latino Spanish is needed, where sometimes more contextual Spanish, depending on if you're dealing with Salvadoreños, Puerto Ricanos, Mexicanos, indigenous language. We have a large Triqui and Zapotec population here in Monterey. And if you just think of the word research, right? We tackled this early on at my former institution. You know, they said you have to say research. Well, research is investigation. Who wants to be investigated, right? That's scary. And you think of all the historic context that goes with that. I think about the Viacom ad, right? I don't know if anyone remembers, they spent millions and millions of dollars. It was all over New York. It was muestra tus cartas, show your cards, get tested for HIV. Well, of course, everyone thought it was a green card. Who's going to want to go and get tested for HIV with that context? Nova, car sales. Nova means doesn't go. And also this new dilemma with social distancing, which I think was one of the biggest things that we did wrong. So too little attention is given to the human side of language, and we really need to get there. Next slide. So I wanted to show you just a little bit. I love what Mexico's doing. It's not social distancing, it's healthy distancing. And everybody wants to distance from someone if it's a potential health issue. So I'd like you to just click on this YouTube video if you could. I think it'll work. I'm hoping it'll work. Maybe it won't work. It's not working? Oh, there she is. Okay, could you just press go? This is Susana Distancia. How clever, right? Your healthy distancing.
Superpoder que me ayuda a frenar al COVID-19. Cuando extiendo mis brazos, puedo crear un espacio de 1,5 metros que me mantiene lejos del malvado coronavirus. Esa es la sana distancia. ¿Sabes qué es lo mejor? Que tú también lo tienes. Pero ojo, aunque tenemos que estar separados, unidos y solidarios, saldremos adelante. Porque si te cuidas tú, nos cuidamos todos. Gobierno de México.
So that is just an excellent example of transcreation and what that can be, right? Just a really outstanding. We're looking at Susana Distancia, right? Susana, now she's a superhero, and people can get that, clicks really well, and then they do it and they think about maintaining distance from others. Go ahead. So, just understanding versus language. So, is it literal or contextual, literacy level high or low, level of formality, casual or formal, art, is it actual or created? Is it representative of the community? Number of words, text versus white space, inquiry, is it open or closed-ended questions or surveys? So the power to convince, motivate, and incite change should always be the guiding force. And being an ethnographer and having spoken to so many communities and individuals throughout the nation, the community often has the answers, and we really need to go there. Next slide. So, I'm just going to encapsulate this because I know I'm running out of time, but usually qualitative data is a really good place to start. It can involve cognitive testing, asking people what they see from messages. And when you think about physical distancing, no one asks people, what does this mean to you? Particularly within marginalized communities. And we should have, because we should have known that this was going to hit marginalized communities more than any other group. Community members or community groups can involve participants in community-based participatory research efforts for materials or campaign development. Next slide. We can ask community members to teach back things. That often works very well, and must budget time for iterations as we're working through. And promotores de salud are a really good, they'll give us what we need to know in terms of what we're doing. And I think about some of the materials that we developed early on, they're still valid. 20 years later, we're still getting requests because these materials last for a very, very long time. They'll endure over a trend. Go ahead. So anyway, fotonovelas, novelitas, you might want to have the content reviewed by a literacy levels specialist, using pan-Latino groups. So we used to use 7 different countries to make sure that everything resonated well with everyone, and allow a period of formative data collection if you can, and develop things in Spanish first and then transcreate to English, right? That's a good way to do it. Next slide. So perfect is the enemy of good. These are just some things around the community that make sense. They're really easy to look at. I was just at a clinic down in Salinas, and these were some of the things that we were looking at. But I really like the Susana Distancia. Turn physical distancing into a superhero. Who doesn't want that? And I think I'm done. Oh, just for everybody to think about in 50 words or less, what's your COVID-19 message? Okay. And I'm going to leave the economic stuff. I know that the slides are being distributed, but again, your message will endure and it will be very cost effective in the long run. There. Thank you very much. Mil gracias.
Thank you so much, Dr. Rios-Ellis. Excellent presentation. It's so important nowadays with this COVID-19 pandemic that we transmit this wonderful message. So I'm going to introduce our next speaker, Dr. Alejandro Cané. He is actually connected from Buenos Aires, Argentina. He is a specialist in pediatrics and infectious disease, graduated with honors from the University of Buenos Aires, Argentina. In addition, he has completed a master in clinical and pharmacological research in Austral University in Argentina. And he also completed the advanced course of vaccinology at Merieux Foundation, France, in the University of Geneva, Switzerland. In the academic area, he served as a professor of pediatrics, infectious disease, and pharmacology. He has written over 100 publications in the field of pediatrics, infectious disease, and vaccines, and collaborated on several book publishing by addressing the same areas. He joined Wyatt in 2006 as vaccine expert, and during the last 15 years, he has played different vaccines, medical, scientific leadership roles in different regions all over the world. Thank you, Dr. Cané, for your willing to participate in this webinar. Muchas gracias.
Thank you very much, Sergio, and the organizer for having me here tonight. And I think the bar is so high after Dr. Vargas and Dr. Rios' presentations, and I will try to fulfill the expectations. So next slide, please. So in the next 15 minutes, I will try to cover where we are in terms of vaccine development against COVID-19 pandemic, looking for information about the different vaccines platform, where we are in terms of the clinical trials, and at the same time trying to build confidence in the COVID-19 vaccines arena. Next one, please. So just to give your attention here, the virus that we are talking about, the SARS-CoV-2, is a very simple virus. It's a RNA virus that is encoding for only 4 antigens. The most important one, the target one, is the spike S protein, which is the key that the virus is using in order to produce infection on the human body. Next one. Next one, please. So up to today, we have seen more than 40 million cases confirmed all over the world. And here you see a picture that I obtained from a website yesterday at night. And here you see United States is still one of the most important countries where the pandemic is having high attack rates. And unfortunately, the following ones are Brazil, Argentina, and Mexico. So South America in particular is being very, very, very affected by the COVID-19 situation. And we have a lot of information that, if you want, we can share at the end of the presentation. Next one. So it is also important to consider why we are working in a vaccine. So when we are thinking about a way to control the pandemic situation, we should put the focus on vaccine. Basically, it's the only one way that will be able to stop the viral circulation. And when we are thinking about vaccine, and you can go through this graphic looking for different points to start into the clinical development plan, there are 2 non-negotiable principles that we are looking for when we are working on vaccines. One is efficacy, and the second one, and most important one, is safety. So all the vaccine programs that are currently ongoing are targeting those important characteristics of any vaccine, which are efficacy and safety. In the next one, you will see that we currently have different platforms that are trying to be used in order to obtain a vaccine. We can go for a very old and very well-known viral vaccines with virus that are fully inactivated or partially attenuated, virus that are produced in the lab or maybe copied from another virus that are including a particular antigen, the protein S that I mentioned before, and those are the viral vector vaccines. And also you have protein-based vaccine, similar to the HPV vaccine or hepatitis B vaccine that we are currently using in our practice. And of course, the genetic platform based on DNA or RNA. On the right-hand side of this slide, you see more than 170 different programs that are already in place, and 12 of them are in the phase 3, so with the latest stage of development. Next one. So in Pfizer, we are working based on a new technology, which is the mRNA platform. Next one, please. So we are working on in a different technology, which is the mRNA technology. Basically, what we have done is once the immunological, the genetical sequence from SARS-CoV-2 was isolated, we copy and we obtain the specific portion of this genetical information that is encoding for that antigen that I referred before, the protein S. And we create a vaccine using that technology. It sounds like a little bit of sci-fi, but it's important because from the safety perspective, the mRNA technology is not working with the whole virus, so we are just using the genetic material, so it's safe from that perspective. This platform has demonstrated already a capacity to trigger antibody response and cellular responses in animal models using other platforms. And of course, it's allowing us to produce a huge amount of vaccines in a very short period of time, which is critically important in a pandemic times like the ones that we are living today with COVID-19. Next one. So, and this slide is summarizing all the steps that we have fulfilled during the last 8 months working in our clinical program. So since March, when the genetical sequence was identified from the virus, we moved into the preclinical studies demonstrating that the vaccine was able to produce an immunological and cellular responses in monkeys and mouses. In April, we started our phase 1, phase 2 clinical trials in Germany, and in May, we did exactly the same in the US. And at the end of July, we were able to identify the vaccine candidate and the exact amount of dose that we are moving into the phase 3. And on July 24th, and you see in the slide, FDA accepted our proposal, and we started our phase 3 clinical trial back in July 27th. Originally, that trial was targeting 30,000 subjects as part of the population that should be involved. And now we are enrolling 44,000 subjects because we included different populations, HIV positive, hepatitis C, and also adults, young teenagers from 16 years old are currently part of the study. So with the safety and efficacy information based on the immunological data that we obtained from the phase 1 and phase 2, we are thinking to submit our results before FDA by end of November in order to have the vaccine potentially approved before the end of the year. Next one, please. And just to summarize where we are, and I think it is very, very important. Yesterday, we have enrolled up to 39,000 subjects. More than 34,000 already were vaccinated with 2 doses. And that is very important. Remember, we are targeting 44,000 subjects as a whole population for the study. The main goal for this study is to demonstrate vaccine efficacy against a COVID-19 confirmed disease in people that was previously exposed to the disease or people that was naive to the disease, which is very, very important. And for that, we are enrolling patients not only here in the US, but also in Brazil, in Argentina, South Africa, and Germany. And next week, we are starting different sites in Turkey. And something that I guess is very important because we were trying to represent the population that is disproportionately affected by COVID-19 in our clinical trial. And as you can see in this table, we have around 30% of the population coming from Hispanic community, Black or African Americans, Native Americans, or Asians. And the other important point that I really want to highlight is the fact that we are enrolling around 50% of the population, considering the older population that, as you know, was suffering severe outcomes with the COVID-19 situation. So with that in mind, as I mentioned before, we are trying to collect all the safety and efficacy information and to be prepared to be submitted at the end of November to FDA. So in the next 5 minutes, I really want to put attention on the other important piece of this situation. We can work so hard and we can obtain a vaccine in less than 12 months, but it doesn't matter if at the end of the day, people are not open to receive the vaccine, right? And I guess there is a very important concept that maybe you are aware already, which is a vaccine confidence. And I hear what I did is just a copy-paste a definition from a textbook when you see that the vaccine confidence refers to the trust that parents or healthcare providers have in terms of recommended immunization, in the provider who administered the vaccine, and in the process and policies that lead to vaccine development, licensure, manufacturing, and recommendation for use. And this is particularly important in the times that we are living today with COVID-19 and all the political implications surrounding the vaccine's development. Next one, please. So just to give you an idea, and this is a picture that you can check out at the CDC website, looking for influenza vaccination coverage in adults 18 years and older in the US, considering different race and ethnicities. And as you see, from 2008 to 2018, there was a light increase in terms of coverage from 30% overall to 42% at the end of the flu season in 2018. However, as you see here, vaccination coverage of racial and ethnic minorities is consistently lower than the one that we've seen in white population. And definitely when we are thinking on a COVID-19 vaccine, we should consider those differences when we are developing messages in order to, not to convince, but to educate the people to be open to be vaccinated. Next one, please. The other important consideration are reflected in this slide and the next one, and you will see that when there was a Gallup survey conducted from July to August, only 2 weeks, and they interviewed more than 7,000 responders, 18 years and older, and the question was so simple. If tomorrow there will be a vaccine against COVID-19 available, and that vaccine is free of charge, are you open to get the vaccination, yes or no? And as you can see on the table here, roughly 70% of the people say yes, I'm open to receive the vaccine, but 30% of them say no. And some hesitancy behind the decisions were there. So we believe that putting in place different communications and messaging, educating the people, that trend will change. So next slide, and you will see that even in a recent survey that was conducted a couple of weeks ago, the situation is even worse than we've seen at the beginning of July. So you see in September 2020, when we were asking exactly the same question, only 50% of the people was open to be vaccinated, and the other 49%, 50% say no. And among those that were open to get the vaccine, 90% of them were comfortable with the way that the vaccine is being developed and being evaluated by FDA. And on the contrary, in the other group, in the 50% that is rejecting the vaccination, they have several concerns about safety and efficacy from a vaccine that was developed in a very short period of time. Next one. So in my mind, which is very important, is to build trust in the process of the vaccine development, right? But there is no way to build trust if you are not providing data. And that is the reason why we should be completely transparent in the way that we are communicating the risk and the benefit in any clinical program. And I think education is critical in that point. And I guess also mentioned by Dr. Vargas and by Dr. Rios, we should adequate the message to the people that we are discussing with. Next one, please. And I put this example here because it was critical for me to understand, even within my family, how you are communicating how it's possible to have a vaccine that usually takes 15 years to be developed in only 1 year. And again, this is only one explanation over several other points that we can discuss if you want during the question and answer session. But here you see, in the traditional paradigm, you are developing a vaccine step by step. You are collecting information and sharing with the regulatory authority, and based on that, you are planning the next step. In the pandemic times, we have worked in a completely different environment, having a continuum of communication with the FDA in the US, with EMA in Europe, and we put together phase 1, phase 2, clinical trials in order to have information and to, in a real life manner, communicate the information to the FDA in order to obtain guidance and to move it forward. And also it is important to highlight that we have received a strict guidance from the FDA that should be implemented in order to be able to apply for emergency use authorization or the final authorization or for full authorization at the end of the 2021, providing not only efficacy and safety, but with a higher bar compared with a traditional evaluation. So that is very, very important to be communicated to the general public. Next one. And this is an important picture. Safety and efficacy, as I mentioned before, are critical characteristics for any vaccine. And this is not only a commitment that the manufacturers have acquired, it's also a commitment that the government in the US is working so hard, and the CDC has developed this slide because it's not only FDA evaluating the preclinical and clinical information, but also after the approval, the CDC and particularly the ACIP is putting in place several ways to capture safety and effectiveness information that will support the use of any vaccine. And in this particular times of COVID-19 pandemic, the monitoring of any signal surrounding the vaccine against COVID-19 will be critical. And in the next slide, you will see how we are planning to commit with that point. So we have a very famous and very robust passive surveillance system like VARS, but also we have a safety data link, which is a proactive way to capture different signals from the safety perspective. And we are currently working in an open collaboration with the CDC, trying to implement an innovative pharmacovigilance program not only one, but all the vaccines that are currently under development will be in the market. And the final one, I think, is just trying to summarize what Dr. Rios and Dr. Vargas said before me. And during the health crisis, communication, engagement, and cultural competencies are critical, and we should adequate our message to the people that we are discussing with. In this particular topic, I guess it'll be very, very important to reinforce the fact that any vaccine that will be in the market in the upcoming 2 months will be rigorously evaluated by FDA, and without safety and efficacy, none of them will be available to use in our country. So with that, I think I can stop and wait for question and answer. Thank you.
Thank you so much, Dr. Cané. Excellent presentation. And I have, actually, I'm going to start with a question about the vaccine. I think Pfizer is one of the 5 companies that are in the phase 3 of clinical trials at this point, and probably one of the leading in having the authorization, emergency authorization for approval. Do you think that it's viable to have a vaccine sometime in November, at least for those populations that are more vulnerable, or we are actually going to next year to be?
So I'll be repetitive, but we are collecting efficacy from the clinical trial, but also safety information, and following the FDA recently published guidance in order to have emergency use authorization. Based on that, we are targeting to have enough number of cases in order to provide efficacy information and the safety requirement information that FDA guidelines include by mid or late November. So with that, you know that the process is to go to the VRBPAC, a particular meeting presented the information, and we are targeting to have the vaccine available before the end of this year. Of course, there will not be enough number of doses to satisfy the whole country demand, and that's the reason why the CDC is working in a very hard manner, I should say, and in an open collaboration with us in order to know how many doses will be available at that time and who should be vaccinated first, and the allocation and prioritization exercise is going to be presented immediately after the vaccine is obtained or is granted with the emergency use authorization. So honestly, I am confident that if the results are positive as we expect, we will have vaccine available in the US before the end of the year.
Thank you very much. We have an early question from Carlos Ugarte. This is for the health literacy panelists. Can you share health literacy data, barriers, strategies specific to Latinos? Can you discuss the relationship between health literacy and social determinants of health? I think it's a broad question, but you can maybe summarize.
Yes, and thank you for the question. What happened is that for health literacy, when we are teaching that, it's kind of one semester, 3-credit class. So you can understand that whatever I have presented is shorter than a summary. Yes, there are tools and there are interventions, and they are targets that are focused just in the Hispanic Latino community. So, and it takes a little while to talk about that, but there are trainings over there, and I can send you additional information if you let us know to your email or where you would like to receive it. But yes, they are target interventions and trainings for people working just with the Hispanic Latino community, including there are like about 7 different validated tools that we can use just for the Hispanic Latino community and assess their health literacy skill levels.
Thank you, Dr. Vargas. This question is for Dr. Cané. Actually, it's a little bit long. People are thinking that the mRNA is modified RNA rather than messenger RNA, and thinking that their DNA will be changed. How do we address this misconception about your vaccine platform?
Yeah, I think it's education, right? Because it's the only way that we can do that. So it's education and communication and trying to explain how the platform is working. As you say, it's an mRNA technology, it's not a modified RNA, and there is no risk to modify the DNA. So that is one of the positive values that the mRNA technology is bringing into the vaccines development platform compared with others. This is a very important one.
Okay, and the same question is, the same person say, I don't understand the race, ethnicity, global figures using USA social constructs?
Yeah, because maybe it's an artifact. We are running the global clinical trial in the US, in Argentina, and Brazil, Germany, and Turkey. So the different racial and ethnicities, of course, are different in the US compared with Argentina and Brazil and others. So we were trying to represent the minorities in the US that are disproportionately affected by COVID-19, like Hispanic and African Americans and Native Americans. Of course, when you are looking for the ethnicity in Argentina, 99% of the Argentinian citizens are Hispanics, like me, and in the US, you know, it's 25% of the population. So we were trying to copy or to be similar to the demographic characteristics. So, and that's the reason why we are targeting around 30% of the minorities represented in the clinical trial population. And we are close to that number. It's 28 until yesterday.
Mm-hmm.
Thank you. I just wanted to, we are actually, this month, we are celebrating the health literacy month. So this topic came in a good time. So you can use the hashtag health literacy month.
Mm-hmm.
I just have a general question for everybody. This COVID-19 pandemic has given a lot of anxiety and has created an atmosphere that is ripe for health misinformation and misleading theories that can undermine safe health practices. Example of dangerous fake news are everywhere, from people fearing that mask wearing is unhealthy to the spread of conspiracy theories that doubt the seriousness of the global pandemic. In 2020, it is very easy to see the effects of misinformation on public health. How we can fight this battle with misinformation, and this goes for not only for the use of masks, social distancing, for vaccines, to how we can gain the trust when some of the agencies nowadays have been politicized by the federal government.
So I've always found when we're trying to deal with really difficult messaging to involve communities in the messaging. So, you know, this is where if I were the president, which obviously I'm not, I would have mass community public health efforts. I would be funding promotores de salud and community health worker efforts all over the place to really get accurate information, because I think we're almost a regime where we are, you know, really promoting misinformation and fake news and people doubting science. And, you know, I was going to ask Dr. Cané, I'm hearing all of these things about people we're not going to have emotions after we get the vaccine because they're injecting some kind of DNA that's going to create robots out of us. I mean, just these insane things with no science to support them. But unfortunately, we have an relatively uneducated population that is taking this stuff in and making it truth in their minds. So to have those community leaders and boots on the ground that can literally be armies of truth and information and answer questions in culturally resonant ways, in linguistic resonant ways, for me, you know, that's the way we're really going to get to marginalized populations.
Yeah.
Yeah, the only thing I can tell is that normally what is happening now is that we are lacking leadership at the top level, because sometimes people receive misinformation that is coming from sources that's supposed to give us information, accurate information. So probably for me, the only thing that I can tell is go to vote.
Let me see if there is any other question here in the chat. I just have a question for Dr. Jackson. So since you are working with the Virginia Department of Health, are you trying to give some advice to the agencies how to implement the health literacy training in the, you know, basically in the agencies, how they can better educate our more, you know, populations who are have sometimes they have very low literacy, as you mentioned in your slide, you know, presentation.
Yeah, we're trying to work on that, but you know that when you're working with the government, they are trying to address critical issues. And you know, when we're working with the health equity, they are trying to address communication issues with the community, and they are trying to address access to testing, access to face covers, et cetera, et cetera. So yes, since the beginning, I put that as one of the important pieces in the strategic plan that we need to have. And I know it's going to be coming, and I hope that before the end of the year. But the training for health literacy is considered a need for not only everybody working in the federal government or the local government, but it's a need for the communities. So the promotoras need to be trained a little bit more in what is health literacy and how they can work together with the rest of the team in helping them to improve, at least in the area of COVID, because this issue is very important for people to increase the credibility on the vaccine, the credibility on wearing prevention mechanisms. So yes, it's part of the plan. My hope is that it's going to come before the end of the year.
Thank you. So I think we are a little bit over the time. I don't see any more questions in the chat. So I just would like to thank you, the panelists, for coming this evening with excellent presentations and for the willingness to participate with the National Hispanic Medical Association DC chapter.
Thank you very much.
Gracias a ti, Sergio. Un placer.
Gracias, Dr. Rios-Ellis.
Gracias.
Gracias.
Let's keep in touch. Nos comunicamos, Alejandro.
Ok. Buenas noches, gracias.
Buenas noches. Chao.
Chao.
Adiós.